Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article entitled Phase 3 Trial of High-Dose Interferon Alpha-2b versus Cisplatin, Vinblastine, DTIC plus IL-2 and interferon in patients with high-risk melanoma, SWOG S0008, an intergroup study of CALGB, COG, ECOG, and SWOG by Lawrence E. Flaherty et al. My name is Jeffrey Weber, and I am a senior member and director of the Comprehensive Melanoma Research Center at the Moffitt Cancer Center in Tampa, Florida, USA. My oncologic specialties are medical oncology and immunotherapy. This article described the results of trial S0008, which was an intergroup phase 3 adjuvant trial that enrolled high-risk resected melanoma patients of stage 3A and 2A through stage 3C and 3 that were randomly allocated to receive either standard FDA-approved high-dose interferon alpha-2b or a biochemotherapy regimen consisting of dacarbazine, cisplatin, vinblastine, interleukin-2, interferon alpha-2b, and G-CSF given every 21 days for 3 cycles. Co-primary endpoints were relapse-free survival and overall survival. In this trial, 432 patients were enrolled with a 1-to-1 randomization. The results were that grade 3 and 4 adverse events occurred in 57% and 7% of interferon patients, and 36% and 40% of biochemotherapy patients, respectively. With a median follow-up of 7.2 years, biochemotherapy improved relapse-free survival with a p-value of 0.015 and a hazard ratio of 0.75, with a median relapse-free survival of 4 years compared to 1.9 years for interferon. The 5-year relapse-free survival was 48% for biochemotherapy versus 39% for interferon. In contrast, median overall survival was not different, with a p-value noted to be 0.55 and a hazard ratio of 0.98, with an estimated median overall survival of 9.9 years for biochemotherapy compared to 6.7 years for interferon. The 5-year overall survival was identical at 56% for either arm. There was no subset for which there was a statistically significant survival benefit for one treatment arm compared with the other. The 2 arms were well balanced for prognostic factors, but it is noteworthy that the median age for all patients was 47, much younger than is usually noticed in melanoma trials at most centers. This suggests a potential selection for better outcome patients, albeit balanced in both arms. While these results are encouraging and provide some evidence that clinical benefit in the form of prolonged relapse-free survival may be provided by a moderately toxic biochemotherapy regimen as adjuvant therapy for high-risk melanoma patients, the lack of survival advantage and the side effect profile as well as the inpatient nature of the biochemotherapy regimen are major disadvantages that will mitigate against its adoption in oncologic practice. Various biochemotherapy regimens have been tested in phase 2 and 3 trials over the last 2 decades and have never been shown to have a survival advantage for patients with metastatic melanoma compared to various control regimens in an era when no treatment clearly provided a survival benefit. A similar biochemotherapy regimen was compared to chemotherapy alone In a U.S. intergroup trial published in the Journal of Clinical Oncology in 2008, after the last patient on the current trial was accrued, with no difference in overall survival seen. The likelihood that the current regimen would prolong survival as adjuvant therapy was therefore low. Today, approved targeted combination therapies provide median survivals nearing 24 months, and clear survival benefit has been shown for the CTLA-4 blocking antibody ipilimumab in randomized trials. Two very promising antibodies against PD-1, a checkpoint protein, provide 30 to 40% response rates with modest toxicity and duration of response of 2 years or more, suggesting that the biochemotherapy regimen in the S0008 trial has had its day and will be unlikely to provide a competitive advantage or an attraction to practitioners in the modern era. When the current trial was designed in 1999, no drug for metastatic disease had ever been shown to provide benefit in a randomized trial. However, since 2011, 5 new drugs have been approved for melanoma, and 2 more are likely this year alone. Have new developments passed the S0008 results by? I would say yes, and in spite of it being a well-designed and carried-out trial, newer treatments with fewer grade 4 side effects will likely become the standard of care for adjuvant treatment of high-risk resected melanoma in the future. The results of the EORTC 18071 trial comparing ipilimumab at 10 milligrams per kilogram versus placebo will be presented at ASCO 2014, and if positive, may provide a new standard of care for patients with resected stage 3 melanoma in the EU. The BRAF plus MEK drugs dabrafenib and trametinib are being compared to placebo in another ongoing randomized trial for BRAF-mutated stage 3 resected melanoma patients. The ongoing U.S. intergroup E1609 trial compares standard high-dose interferon to ipilimumab at either 3 milligrams per kilogram or 10 milligrams per kilogram, and if positive for either ipilimumab arm, this could establish a new standard of care in the United States. Several adjuvant trials with PD-1 antibodies nivolumab from Bristol-Myers Squibb or MK3475 from Merck are in the planning phase. Where does biochemotherapy fit into this equation? Does prolongation in relapse-free survival of 24% overall and 8% at 5 years not constitute benefit for high-risk resected melanoma patients, even without a survival advantage? The answers are that for the majority of melanoma patients that receive their care outside an academic center, the cost-benefit quotient and the promise of newer, less toxic outpatient drugs make it unlikely that biochemotherapy will get much use in the future as adjuvant treatment for high-risk melanoma patients, nor will it be adopted as a standard against which new adjuvant therapies will be measured. While the authors of the current article correctly state, quote, "The present study is the first to demonstrate an improvement in relapse-free survival compared to high-dose interferon," unquote, relapse-free survival is primarily a surrogate for the ultimate clinical endpoint, which is overall survival. The former, without the latter, might occur in a scenario in which multiple effective drugs might be available for use post-relapse, and overall survival might have been confounded by a crossover effect. In the SWOG 0008 trial, which accrued patients from the year 2000 up till 2007, some patients may have gained access to newer drugs post-relapse, but that number would seem small given the period of time in which its accrual occurred, suggesting that the trial's survival data are unlikely to be tainted by treatment with new drugs that we now know will prolong survival in stage 4 disease. This highlights the danger of conducting a randomized phase 3 trial that extends over a long period of years like the S0008 trial did, because in the interim, new drugs and new treatment paradigms may change the standard of care. In this case, that is exactly what has happened. The number of relapses during the period of biochemotherapy was much less than during the year of high-dose interferon, although the former period was much shorter, and that result is hard to interpret unless one postulates only a transient beneficial effect of the biochemotherapy. In conclusion, the SWOG 0008 study was well conceived and carried out, but conducted in an era prior to the wide availability of effective drugs for melanoma. As time goes by, the field has moved on also. This concludes this JCO podcast. Thank you very much for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.